There we go. Okay, thank you. So let's get started because this is going to be a morning just packed with wonderful information. And I'd like to introduce myself. I'm Gina Orr, Chief Philanthropy Officer at Sun Health Foundation. And we just so appreciate your joining us this morning. I think that taking care of our health should be a priority every single day. And I know many of you do that. So we applaud you for wanting to stay up to date, to be informed, to be educated, to be proactive on how you can best take care of your health. And we have some experts with us today who are just amazing. And you know, when I was talking with Shirley this morning, I was telling her that we had heard from Dr. Murphy and Dr. Lawther last week. And I said, my goodness, they're so young, but they're all getting so young anyway. I guess it's just a sign of the times. And so as these young medical professionals come to help us be well and stay well, you know, they are aggressive in their thirst of knowledge on technology and best practices and innovation. So we applaud all of that. Now, I want to be sure, I'm talking on and on, but I just want to be sure that everybody can hear me or see me. So if you can give me a wave of your hands or a thumb up or put something in the chat or down below where you can give us a smiley face, I just want to be sure that we're coming across well. There we go. Thank you. I see people waving. Great. Thank you. Okay. Okay, so let's just proceed. And I have the privilege to introduce our special guest today from Banner MD Anderson Cancer Center at Del Webb in Sun City West. Dr. Brittany Murphy is a breast surgical oncologist, and her sidekick and partner, Dr. Hannah Lawther, a breast radiologist. They'll be happy to respond to your questions as we move forward. So there's a picture of Dr. Murphy. I'd like to introduce her and give you some of her background. Dr. Murphy completed her general surgery residency at Mayo Clinic in Rochester, Minnesota, dedicating a year of training to surgical outcomes research focused on breast cancer. And she completed a breast surgical oncology fellowship at University of Texas MD Anderson in Houston. I think we all probably know that that's the big MD Anderson Center. She will discuss how breast cancer is diagnosed, basics about how it is treated, and innovative options that you'll be thrilled to learn about. This next slide shows Dr. Hannah Lawther. Dr. Lawther completed her diagnostic radiology residency at the Ohio State University Wexner Medical Center and a women's imaging fellowship at the Mayo Clinic in Arizona. She will talk about imaging, when to start and stop screening, indications for MRI, and the radiology services available. Again, they both practice out of the Louisa Kellum Center for Women's Health at the Banner Del Webb Medical Center in Sun City West. She will also share and she really is focused and passionate about helping people understand how to manage their breast health. And so the more that we know about new developments in breast cancer care, the more empowered we will be in our own health and well-being. So before we begin the presentation, I just think many of you may have heard this story, but I also am proud to continue to share the story that the Sun Health Foundation has been around for 5+ decades. It was a group of volunteers, very much like on this call today, who came together to pass the hat, to raise funds and to secure the resources to build the Boswell Hospital in 1970. And then they headed west on Grand Avenue to build the Del Webb Hospital in 1988. And they became an entire healthcare system in the West Valley. So we partnered with Banner, the nonprofit Banner Health, in 2009 so that we could continue to be sure that these wonderful healthcare services are available to those who live, work, and play in the West Valley and beyond. So we continue to be the philanthropic link to ensure that these hospitals are well-funded, and we have learned that well-funded hospitals that can expand, like the emergency department at Boswell, that can acquire amazing equipment, like you'll hear these two medical professionals talk about, that's what recruits and retains the best medical professionals to provide you with the best medical care. So without further ado, because I know you didn't really come to hear me talk, let's begin their presentation. Joyce, are you ready?
I'm ready.
Okay. Dr. Lawther, you're on.
Okay. Can you hear me okay?
Yep.
Yep. Okay, I think actually Dr. Murphy's going to start off.
Wonderful. So thank you, Gina, so much for the introduction. Thank you, everyone, so much for your support and for the opportunity for us to speak with you today about breast cancer basics and new advancements in treatment. If we can advance the slides, please. Perfect. So today, what we're going to talk about is we're going to go over some breast cancer facts, followed by the ways that breast cancer is typically diagnosed, breast imaging recommendations, and then finally we'll wrap up with the basics on treatment and the new advancements in care. So breast cancer is very common. About 1 in 8 women will be affected with and diagnosed with breast cancer in her lifetime. And this equates to just over 12%. We know that it is estimated in 2021 alone that over 280 women will be diagnosed with invasive breast cancer. And then an additional almost 50,000 women will be diagnosed with DCIS. And DCIS is a stage 0 breast cancer. Breast cancer doesn't only affect women. And so approximately 2,600 men will actually be diagnosed with invasive breast cancer this year. And that equates to about 1 in 833 men. So it's very rare, definitely when compared to female, but it can happen. And then unfortunately, even though breast cancer outcomes are very good, just over 40,000 women will die of breast cancer this year. And then as of January of this year, more than 3.8 million women in this country will have either be undergoing ongoing treatment for breast cancer or have a history of breast cancer. So it is just so common. And it is the most diagnosed cancer in American women. This year alone, 30% of all cancers that are diagnosed will be breast cancer. Risk factors for breast cancer, the 2 most common are being female and age. So as our age gets older, the likelihood of breast cancer goes up. 2/3 of cases that are diagnosed are in women greater than 55 years of age. So it's in our postmenopausal women that it is most common. Other factors are family history and genetics. So genetics and family history go hand in hand. And so with genetics, only about 5 to 10% of our patients will have an actual known germline mutation that can be passed down from generation to generation. However, we do know that family history, even without a genetic mutation, does play a big role. Also, if a patient had radiation to their chest wall between the ages of 10 and 30 years of age, they're also at a higher risk of getting breast cancer. Obesity is also related to breast cancer, as a lot of the adipose tissue secretes estrogen, and that is one of the main feeders of breast cancer. Also, if the woman has no children, or if the first birth was after age 30, or if they don't breastfeed, it can slightly increase that risk for breast cancer. Along with that, if the age of their first period was before 12, or if menopause is after 55, it slightly increases that. And all of those are because of the levels of estrogen in the body. Along with that, hormone replacement therapy can slightly increase that risk as well, and alcohol use. Breast cancer diagnosis, what we want our patients to really watch out for is any changes in the breast. Anything that is new, please let your doctor know as soon as possible. And so specifically, things that we are looking for is a palpable lump. If there is a new skin puckering or dimpling, if the skin is red, if the nipple has any changes, so just like a scaliness of the nipple that doesn't go away, especially with lotions. If the nipple normally points out, but now it's starting to point inward, or if there's a new nipple discharge. These are all things that we really make sure to let your doctor know. And then also make sure to get your screening imaging. It's very important. Breast cancer is most commonly diagnosed based on screening imaging. And Dr. Lawther will go into more on imaging for us.
All right, go ahead and advance the slide. So first off, has mammography actually reduced breast cancer death? And And the answer to that is yes. Since 1989, which was when mammography became more commonplace, hundreds of thousands of lives have been saved by the use of screening mammography, as well as new developments in treatment. This graph here shows that prior to the widespread availability of screening mammography, the breast cancer death rate was fairly constant. However, since the late 1980s, the breast cancer death rate has decreased by more than 40%. And so, as I was saying, since the widespread use of mammography, there's been a 40% decrease in breast cancer death. And for the breast cancers that are detected via mammography, they're usually less advanced and requiring, therefore, less extensive surgery and less chemotherapy. And when chemotherapy is necessary, that chemotherapy tends to be more effective for women whose breast cancer was diagnosed via a screening mammogram. So what are the recommendations? I know they can be kind of confusing, but the American College of Radiology, which is what we use as our gold standard society, recommends annual, meaning once a year, screening mammogram, screening meaning no symptoms. So no palpable concerns or no redness, no pain, etc., for an average risk woman starting at age 40. Average risk, and I'll define what high risk is in an upcoming slide, typically means that based off a lot of those different risk factors that Dr. Murphy went over before, your risk, once calculated into a computer that your physician or provider can do for you during your annual appointment, that risk comes out to less than 20%. So for a lifetime. So for an average risk woman, we recommend getting a mammogram once a year, every year, starting at age 40. Question being, when should mammography stop? Well, there's no hard or fast answer to that, but we typically say the recommendations are that that annual mammogram should continue as long as you're in good health and you're expected to live 10 years more or longer. So that's going to be a different number or different age for many different women. So why do we recommend starting screening mammography at age 40? Well, 1 in 6 breast cancers are found in women between ages of 40 and 49. That is twice the amount, more than twice the amount in women younger than that. And the cancers that are found, even though they're relatively rare, but not so rare, they tend to be more aggressive. And so the earlier you're diagnosed, the more aggressive the breast cancer often is. And so by starting screening mammography at age 40, then we actually save about 1/3 of all years of life potentially lost from breast cancer are in women in their 40s. And that's largely due to screening not being as common, and also just the aggressiveness of the tumor, the younger you are. Okay, the next slide. So you go and you get your mammogram once a year. What are the risks of getting that mammogram? Well, 2 things can often happen. You'll get a letter in the mail or a phone call, and for 100 women, 90 of them, or 9 out of 10, will be told that their mammograms are normal, nothing to worry about, and that we'll see you in 1 year. So more often than not, 9 times out of 10, we'll see you next year. 1 out of 10, or 10 out of 100 women, will be asked to return for additional views. And so of those 10, we'll do a couple more additional views, and that would be often via additional mammogram or a breast ultrasound. And of those 10 women, 6 of those women will be told, okay, everything is normal. See you in a year. 2 of them, so 2% would be asked, actually, we think this is probably nothing, but we'd like you to return in 6 months just to make sure. And 2 of the 10, so 1 to 2%, will be recommend that we have a biopsy. So recall, meaning being asked to return after your screening mammogram, is about 1 in 10 women, and then biopsy is about 1 in 100 women, 1 to 2 per 100. So it's pretty rare, but that's kind of the expected sequence after getting your annual mammogram. So higher risk women, before I mentioned that average risk, meaning less than 20% lifetime risk of getting breast cancer, should get their mammograms once a year, starting at age 40. Well, for higher risk women, and that is defined as women who have a lifetime risk of breast cancer, 20% or greater. And again, there are different calculations, and they're nothing fancy. They're just asking questionnaires, and they can calculate that risk. And so for women with this higher risk women, we recommend that they get a mammogram and most often an MRI starting at every year at age 30. What we typically like to do is we like to stagger the mammogram and the MRI. So say you get your mammogram every year in January, then ideally you would get your MRI every year in July, so that your breasts are actually being imaged twice a year, but you're still only doing that modality once a year. And so some of these, the women that are considered higher risk is if they have a known what we call a BRCA1 or 2 mutation, and they have a much, much higher risk. BRCA just means breast cancer, so it's the breast cancer gene. Also, if you have a first-degree relative with a known mutation in the BRCA1 or 2 gene, in first degree being a parent, a brother, a sister, or a child, and you yourself have not had the genetic testing themselves. Or if you had radiation to the chest when you were between the ages of 10 and 30, most commonly due to a history of lymphoma. So the majority of women do not fall in that greater than 20% risk, but the ones that do, starting earlier and doing the supplemental screening with a breast MRI is very important. So what type of breast imaging do we offer at Banner MD Anderson? So first off, where are we? So we have 3 different sites in the Valley. I personally work at the Louisa Kellum Center for Women's Health. I occasionally will go to the other centers. We also have one downtown at the BUMCP, which is associated with both the University of Arizona, as well as Banner MD Anderson. And then the Banner MD Anderson as well in Gilbert at Gateway. So, and then the Louisa Kellum Center, which is where I'm based out of. And so all 3 of these sites are associated with Banner and the MD Anderson Cancer Center. So with these 3 sites, you, if you come to any of these 3, you will have all of these different options that I'm about to talk about. They will all be offered to you there. And who we are. So all 3 of our Banner MD Anderson sites have been designated as breast imaging centers of excellence by the American College of Radiology. This is the gold standard. It's the most stringent certification process. And there aren't that, the majority of breast centers, or the majority of centers where you can get your mammogram do not have this designation. But here, all 3 in the Valley, including the Louisa Kellum Center, have this designation and have it for a very long time. Also, all of the radiologists, which is what I am myself, not only did we do a year or 4 years of medical school, a year of internship, another 4 years of residency, all of us also have done another 1 year subspecialty in only breast imaging. So we're all full-time, only do breast and only work dedicated at the breast centers. So what do we offer? So we offer all of the most up-to-date technology here. So we have what we call 3D mammography. So during a 3D exam, you stand in the machine and it compresses your breast, and an X-ray arm sweeps in an arc over the breast. And as it does that, it takes multiple low-dose images. Then a computer will synthesize a 2D as well as 3D images of the breast from that exam. And then we can scroll through, kind of like a book, and we can look at 1 millimeter slices of actually the breast tissue. And that's called a 3D mammogram, or a tomosynthesis. What's nice is that the computer that we have and use, it can synthesize a 2D mammogram from these 3D images. And so that actually cuts the radiation dose in half from a mammogram, because we don't have to do a separate 3D and 2D. We can synthesize the 2D and they're just as accurate, cutting the radiation dose in half. So the ability to scroll through these images, it increases the breast cancer rate by approximately 25%, which is high, 1 in 4. It also decreases the number of callbacks, which I talked about on the other slide, by about 15%. We also have special AI or artificial intelligence software that also helps recognize subtle changes in breast tissue, particularly when compared from year to year. Additional services that we use to image the breast includes high resolution breast ultrasound, which does not use radiation. It uses sound waves, and it produces pictures of inside the breast. Ultrasound is safe, it's non-invasive, like I said, and it doesn't use radiation. Other modalities is an MRI. MRI uses strong magnets, and it can be an additional screening tool for women who I was mentioning before are at high risk for breast cancer due to family history or mutations in genes, as well as it can be a diagnostic tool to kind of evaluate the extent of disease in a newly diagnosed breast cancer patient. And we offer all of that at all 3 sites. So additionally, say we find something in a breast and we do additional imaging and we determine that we need to do a biopsy of that. Well, we can do a biopsy using the mammogram, using it as a guide, using ultrasound as a guide, and using MRI as a guide. We prefer to use ultrasound if at all possible. It's quicker, faster, cheaper. And all of the biopsies we do in the actual Louisa Kellum Center. And myself or one of my colleagues would do it. And what we do is we numb your breast so that you don't feel anything. But it's nice because there's no going to sleep. You can drive yourself here, drive yourself home. And it's a pretty painless procedure, very, very well tolerated. And it's minimally invasive. There's no stitches or anything like that, just a tiny little steri strip. We also can do biopsies using the same equipment of the lymph nodes or the areas in the armpit that are suspicious. And then we can also drain any infections in the breast, as well as cysts that may be causing discomfort. One of the other things that we do, and Dr. Murphy and I work hand in hand with this. So let's say that something's been found in the breast and a biopsy's been done and it's a small tumor and you need to have surgery. And Dr. Murphy will get into this in a little bit, but there's different types of surgery. More often than not, you can just remove the tumor, the small tumor. And again, by getting a mammogram every year, we're more likely to find tumors when they are small. And so previously, the day of surgery, you would come in and a wire would be placed in the tumor. Well, now we've gone away with wires and we use something that's is the most up to date. In some places actually still are using wires, but we at Banner MD Anderson use 100% of something called a radioactive seed. And this tiny seed is about the size of a sesame seed. So I'm talking very tiny. And using a mammogram or most often ultrasound as a guide, I will place that tiny little seed with a tiny amount of radiation into the tumor. And I can do that up to about 7 days before your scheduled surgery. So the day of surgery, then Dr. Murphy will use a handheld little machine that can kind of like a metal detector at the beach. I kind of liken it to sometimes, and it'll go beep, 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 beep. And she can use that to find the tumor without having anything sticking out of the breast. And then once the seed is removed with the breast tissue, all of that radioactivity, which again is a very, very tiny amount, is eliminated from your body. So it's usually only in there for 1 to 2 days, and it just lets you have the most accurate surgery possible at the time. And so some of the advantages of the seeds that we offer, we'll say one of the main ones is kind of decoupling the surgeon and the radiologist schedule. And so we can place this tiny little seed up to a week before. And so you don't have to come to the hospital really early in the morning, the day of surgery, and then wait with this wire sticking out, and then you can't eat anything. So overall, it's a much more comfortable experience for patients, as well as the seed's more accurate. The wire can get dislodged, etc., and the seed's just in there. And then also the surgeon knows exactly where to go to more accurately plan for her surgical incision, etc. So here's just, I'm just going to show a couple pictures. This is just an example of what a mammogram looks like. You get told every year your mammogram is normal, but what actually does a mammogram look like? Well, this is a mammogram, and this is a synthesized 2D. And this was a patient who presented where the arrow shows she felt something in her breast. So this would be called a diagnostic mammogram, unlike a screening mammogram. And where those arrows show, and so on the right, I don't know if you can you see my arrow moving? Maybe not. So yeah, so that's the right breast, and then on the opposite side is the left breast, and on the left is showing what we call a CC view, and so that's medial and lateral, and on the left it's showing the upper and the lower part of the breast. And then in the armpit area, those are little lymph nodes. And so this is what a mammogram looks like. And so the darker area is fat. And so all breast tissue, both in men and women, are made up of fat and fibroglandular elements. And so the white areas are the glandular elements. And where the blue arrow is, that's showing where a 1.5 centimeter little mass is. Her left breast was negative. So if you want to go to the next slide, this is an ultrasound. And so this is what ultrasound images look like. And this is the mass corresponding to the area that she felt. We looked at her armpit as well. We always do that. And because the lymph nodes status is, again, Dr. Murphy I don't know if she's going to mention this in the end, but that's the #1 prognostic, or one of the top prognostic factors of breast cancer, is whether or not the breast cancer has spread to the lymph nodes at that time. And so when we're recommending a biopsy, we always take a look at the lymph nodes. And so this lymph node looked a little suspicious. And then this mass measured about 2.7 centimeters. So the mass is on the right two images, or the darker areas, where the normal tissue is the surrounding, on the left side, or is the mass. And those two images, that's where the actual cancer is. And so we recommended that she have a biopsy. And so on the next image, or the next slide, I'm sorry, this is an example of what we use. Here we used an ultrasound as our guide to do the biopsy. And so this white linear line in the left two images, that's the biopsy needle. And it's going through the mass, and we take a couple of tiny samples of that. For this example, we took we biopsied 2 different areas, and at the time of the biopsy, we placed 2 tiny little clips, and the clips just mark that. And we usually use different shapes. And so then for this patient, she actually underwent what we call neoadjuvant treatment, neo meaning before. And so she underwent chemo before actually having surgery. And so on the next slide, so here's an MRI. And so this is what an MRI looks like, the other modality that we use. Her left breast is negative, and the white kind of squiggly lines that you see throughout the breast, those are blood vessels. Those are normal. That's the heart behind the breasts right there. And then that's the blue arrow, that's the tumor. So that's the area in her right breast and it measured up to about 4 centimeters. So we did chemo for her, and then she came on the next slide, and then we re-imaged her before surgery, and then that area did very well. It now measures up to 1.1 centimeters, where before it measured up to 4 centimeters. So this is a mammogram, and so this is kind of the stepwise process of how a patient who presents with a symptom and the typical imaging that can be done. And so I just wanted to show an example, just to talk about these things. A lot of people actually probably wouldn't have ever seen what a mammogram looks like. So on the next slide, these are just some of the additional breast services that we offer together here at Banner MD Anderson. And a lot of these services work hand in hand with multiple different departments. Myself in the radiology department, as well as in the surgery department with Dr. Murphy's department, as well as the oncology, which is often the department that gives out chemo. But one of the things we have is something called a breast cancer navigator, or BCAN navigators. And so our navigators, this is their full-time job, and they provide one-on-one assistance to all new breast cancer patients, which is very, very helpful. And patients, and they're all very kind and patient women, and they just help, kind of navigate you through through this kind of scary time in your life. And they know the different resources available, both at the medical system as well as in the community. And they also help keep, and they make your appointments as well as help you remind them. And they also streamline communication between our different departments and the different physicians. And so by having the coordinators kind of alongside you as you go through this kind of treatment journey, you do really do get the best possible care as well as experience. And the next, so we have something else called the Undiagnosed Breast Clinic, or UBC. And that is, so if you have an abnormal screening mammogram, or you find a breast lump and you're like, I don't know what to do. Well, you can make an appointment at our Undiagnosed Breast Clinic. And either you can do it yourself, or you could be referred by one of your physicians. And so when you make an appointment through the UBC, then you're scheduled for a morning appointment with a physician in the clinic who will evaluate you. And then you'll come over to where I'm at the Louisa Kellum Center. And then we'll do all that imaging to kind of wrap up everything and to get all the answers that same day. And so sometimes you would need a biopsy, and we can either do the biopsy that day or the day after. And then we get the results within 48 hours, so 2 days, and then we call you with those results. Also, we can help arrange, if this does come back as something that is cancerous or needs to be surgically removed, we help facilitate all of those appointments. And, one of the other different services we have is we have what we call our tumor board. And so we have it every Thursday, and it's a very comprehensive. And so all newly diagnosed breast cancer patients in our system, we meet and with the radiologist, myself, the surgeon, Dr. Murphy or Dr. Russell, the radiologist or the radiation oncologist, geneticist, and we go over every patient and we discuss, okay, would this patient benefit from just removing part of the breast or removing all of the breast? Or are there any trials that this patient would benefit from? Or this patient has this aspect or this medical history that would make them unique in something else. So it's a very multidisciplinary team approach to patient care. And we also, like I said, we collaborate with the MD Anderson Cancer Center in Houston, which is ranked the #1 cancer center in the United States, in the U.S. World News Report. And we collaborate and we use we have access, and we work together with all the clinical research and trials. Okay, so I'm going to let Dr. Murphy go over breast cancer treatment now. Any specific questions before we again, you can ask questions at any time as well as at the end. But if there are any questions that anybody has in regards to breast imaging, I'm absolutely happy to answer any. Or we can let Brittany continue and we can take questions at the end as well.
Dr. Lawther, this is Gina. Or I do have a question in regard to your excellent presentation and this information you're sharing with us. I have particular interest in learning a little bit more about the navigator. So does the navigator come alongside a patient only during treatment, or is that
no? So they'll come alongside after the biopsy. So the navigator often will help get the biopsy scheduled. So that's even before cancer diagnosis is ever made. And then if that biopsy comes back as cancer, the navigator will call and they will say, okay, this has come back something that we need to do more work on. And this is what we have to offer here. By no means do we make you come here. Every patient is welcome to go wherever they want to go. And they will give information about different systems, or they'll give a list, but here's a list of all of the different surgeons in the valley, in the area. Here are the ones that we have here, and if you choose to continue your treatment here, then this is what we have to offer, which I kind of highlighted. And then we will help make that appointment. We'll do the referral so that they can get seen by a breast surgeon here within the next day or two. And so and then they will be alongside your journey as you continue through treatment. But oftentimes one of the most important jobs is getting you plugged in and to kind of coordinate that treatment and what's the next step, because it is scary. It's a time of unknown, and having that navigator and having somebody to kind of help facilitate all these appointments and to facilitate them happening quickly, I think a lot of patients appreciate. I know I would. And then they're also just a nice contact. If you have any questions, if they don't know the answers, they'll contact us, or they'll say, Dr. Lawther, do you mind giving this patient a call? She had a question about X, Y, or Z, and then we'll give you a call, within the hour or so. So they would, ask, or direct the question to Dr. Murphy, et cetera.
Well, thank you for that, that answer. And just now, just for clarification, when you say here, you mean at the Louisa Kellum Center for Women's Health?
Yep, that's the Louisa Kellum Center, yeah.
Because Boswell focuses a little bit more on the lung cancer piece, but Webb.
Yeah. So when I say here, I am just referring to the Louisa Kellum and the Del Webb.
Okay, and then one more quick question. I don't mean to kind of derail this, but curious. So I know that Banner MD Anderson medical professionals and the culture at Banner MD Anderson really is not only about outcomes, but about the patient experience. Yeah. So the navigator component, is that something that is unique to Banner MD Anderson, or maybe perhaps you don't know that?
No, it's not. It's not unique to Banner MD Anderson. A lot of the large academic medical centers, they have them. But more often than not in the community, they are not found. So I don't want to speak to other hospital systems that I don't know their exact, but for example, I did my fellowship at Mayo, and there's a navigator at Mayo in Arizona.
And so other like, oh, I'm sorry. But
other just like standalone imaging centers, say, you just go to an imaging center that's on the street, that's not associated with the hospital or a medical system, they're not going to have a navigator. They will do your biopsy, but then you're going to get this result that says, I have cancer, and that's scary. What do I do? Who do I call, etc. And so that's where the navigator really plays a role. You get your biopsy here or elsewhere, and the programs that have the navigator, they call and say, okay, this needs, further workup, but here's a list of people that you can go to. I can make this phone call for you. I can help make this appointment. We can have you seen by Dr. Murphy or Dr. Rosso across the street at Banner MD Anderson or Louisa Kellum tomorrow. Would you like that? And so that's where the navigator helps really navigate that whole process.
Wonderful. That's such a wonderful service. Are the navigators typically nurses?
Some of them are nurses and some of them are mammo techs, but then they undergo a special certification process and training just in this breast cancer navigation role.
Great. Well, thank you. Appreciate that. Didn't mean to put this down a new pathway, but I thought that might answer some questions for others as well. So if there are questions, we're happy to take those. Otherwise, we can give the microphone back to Dr. Murphy.
Yes, one quick question, please, about diagnostic versus screening. Doctor, how long after you've had breast cancer is it necessary to continue to have?
That's a really good question. So what we typically do, there's no real, unlike the ACR saying get a mammogram once a year starting age 40, they're kind of left up to, so we still recommend always getting a mammogram once a year. Well, what's the difference between a screening mammogram and a diagnostic mammogram? Well, they're the same imaging, but a diagnostic, they both do 4 views of the breast. The difference is that the radiologist is going to read your diagnostic mammogram while you're still there waiting in the waiting room. And then if I tell the technician, hey, I'm going to need another view, do you mind going in and doing another view? Then they'll do that other view while you're still waiting there. And then I'll say, okay, maybe I just want to get an ultrasound. And so then the radiologist will come and speak to you most often after the diagnostic mammogram. Where a screening mammogram, you get your mammogram and then we read it that day, but you might not get the report, the next day or the letter or the phone call. So for what we do here is for you've been diagnosed with breast cancer, typically we do a follow-up diagnostic mammogram in 6 months. Just on that side. And then we do a mammogram once a year, which is again the same recommendations that every woman have, but we recommend that it be diagnostic for 5 years. And then after 5 years, we recommend you just go back to regular screening mammogram, which again is the same imaging. It's just not, you don't have to wait for the results. Does that make sense?
Thank you.
Yeah.
Thank you so much.
Yeah, absolutely.
Okay, well, I will then go on for breast cancer treatment. So just like Dr. Lawther mentioned, so breast cancer is treated in a multidisciplinary fashion. And so what that means is it's a surgeon, a radiation oncologist, and a medical oncologist that are all working together to form your treatment plan. And again, something that is unique to Banner MD Anderson is also can be found at other academic medical centers, but is our multidisciplinary connection. And so again, all of our patients that are diagnosed with breast cancer are presented at our tumor board, where we review the entire case with Dr. Lawther, one of our colleagues, our pathologist, and all three of these disciplines. And then there is also an opportunity for the patient to be seen at our multidisciplinary clinic, where they are seen by a surgeon, a radiation oncologist, and a medical oncologist all back to back. So they get all three treatment appointments on the same day. If that is not something the patient wants, or if for other specific reasons, we do make sure that we get them into all of the different therapies to have a consultation with them. And so breast cancer treatment is really guided by the tumor stage. And so breast cancer is staged in two different ways. So first is based on the anatomic stage, and that's off of the TNM staging criteria is what we refer to it. So T stands for tumor size, and then N stands for nodal status. And so like Dr. Lawther mentioned, really one of the most prognostic indicators for breast cancer is this nodal status. And so we really want to know if there's any abnormalities in those lymph nodes. And then the M stands for metastasis. Has breast cancer gone anywhere? Then we also want to know for breast cancer, what is the tumor biology? And this is unique for breast cancer, that we know that breast cancer feeds off of different things. And so the most common are the female hormones. So that's the estrogen and progesterone. There's also this HER2 protein that we know that can also cause the tumor to be more active or more aggressive. And so we really target and make it a specific treatment for the patient based on all of these factors. And so the anatomic stage, again, is mostly based on the size. And then that prognostic stage also incorporates the tumor biology. And so the treatment will be specific to each patient depending on the size of their tumor and that tumor biology. And so again, breast cancer treatment is focused on surgery, radiation oncology, and medical oncology. And so one of our biggest questions is how chemically, how systemically are we going to treat this? And so chemotherapy is recommended typically depending on the size of the tumor and the lymph node involvement, along with the tumor biology. And so all of these are taken into account when the recommendation of chemotherapy for or against is given. If chemotherapy is going to be recommended, sometimes, like Dr. Lawther mentioned in her case example, is given before surgery. Sometimes it's given after surgery. It's all dependent on the patient, and we make each individual a patient assessment. And then one of the new advancements in medical oncology and breast cancer treatment is what's called an oncotype score. And so what an oncotype recurrence score is it is a 21 gene panel assessment that is sent on the tumor itself. And so typically you'll go to surgery, and then if it's an estrogen and progesterone, which is abbreviated as ER and PR positive tumor, HER2 negative, we can send the specific test to look at all these genes and figure out how much chemotherapy would benefit a specific patient in that specific tumor. And so it'll come back with a percentage. And so we will know for that specific patient that chemotherapy will help this from coming back by X%. And then the doctor and the patient can undergo shared decision-making and come up with what that percent means to them and determine if they want to undergo chemotherapy. And then also hormonal blocking medications are often recommended for 5 to 10 years after breast cancer treatment if the cancer is an estrogen or progesterone sensitive tumor. So in terms of surgery, there are two main ways that we can treat breast cancer. One is a lumpectomy, the other is a mastectomy. So for a lumpectomy, like Dr. Lawther alluded to, this is a removal of the abnormality with a small rim of normal tissue around it. And so if we cannot feel the abnormality, this is when we will have Dr. Lawther or one of our colleagues put in one of those radioactive seeds in the tumor. And so after the breast biopsy is performed, typically a small clip is placed. But as a surgeon, we can't identify that clip in the operating room. So Dr. Lawther would put a seed next to that clip. And then we use that little probe in the operating room to identify where this tumor is. And we remove it with a small rim of tissue. The other option on the next slide is a mastectomy. And so with a mastectomy, we remove the majority of the breast tissue. And so it's not possible to get all of the breast tissue. We really try our best to do that, but because of the border of where the subcutaneous tissue and the breast tissue goes, it's impossible to remove all of it. And so even with a mastectomy, there is a small chance that it can recur in the future. And so we call the recurrence rates and the outcomes between a lumpectomy and a mastectomy to be the same. And so overall survival is the same. And local recurrence really is about the same. It's slightly higher for a lumpectomy than a mastectomy, but we really call them equivalent. And so for a mastectomy, there are 3 different types. And based on the tumor location, the tumor size, and patient factors, we can perform one of the 3 types. So a total mastectomy is when we remove most of the breast, we remove the nipple and the areolar complex, most of the breast skin, and then the majority of the breast tissue. For a skin-sparing mastectomy, we remove the nipple and the areolar complex, but we save most of the skin. We still remove all of the breast tissue, but we have this skin pocket. So then we can work with a plastic surgeon that I didn't mention, but it's also part of the multidisciplinary care team. Our plastic surgeon comes in right at that same time of surgery, and we'll do the first step of the reconstruction at that time. The other option is a nipple-sparing mastectomy, when we actually save the nipple, the areolar complex, and all the skin, and then all the breast tissue is removed, and then our plastic surgeon will do the first stage of the reconstruction at the same time as the initial breast surgery. The other part of the surgical treatment of breast cancer is lymph node evaluation. Most commonly, this is done with sentinel lymph node surgery. And so like Dr. Lawther mentioned when she was showing that ultrasound of the axilla, we really take a look to see if there are any suspicious lymph nodes at the time of diagnosis. So if there are not, one of the other advancements in breast cancer care is really making it a specific recommendation to do sentinel lymph node surgery. So now national guidelines are recommending that for patients that are over 70 years of age, we really do sentinel lymph node surgery on a case-by-case basis. And so if we have a really low suspicion that the lymph nodes are involved, plus other factors, we may recommend that we actually do not do sentinel lymph node surgery these days. But classically, sentinel lymph node surgery is recommended. And so we know from many studies that breast cancer drains to the lymph nodes typically before it goes anywhere else. And it will drain to a few lymph nodes before it drains to all of them. Most commonly, 97% of the time, it drains to the lymph nodes underneath the armpit. And so we can use 2 different dyes to identify these sentinel lymph nodes. And so we specifically will remove these targeted lymph nodes. Every woman has a different number, usually between 1 and 4. And then we send those to our pathologist to review. And then based on what breast treatment the patient had, different recommendations are made if cancer is found in the lymph nodes. An axillary lymph node dissection can be recommended if there is disease in the lymph nodes. One of the main risks that everyone is worried about is a risk of lymphedema after an axillary lymph node dissection. Lymphedema, again, is one of the most feared complications. And as you can see on this slide, it's a swelling of the arm. And why it's feared is because it's a chronic swelling of the arm. And so there are really no great cures for lymphedema. There are ways we can treat it, most specifically with different massage techniques and compression garments. But if we can prevent it, we'd like to. And so rates of lymphedema for sentinel lymph node biopsy are pretty low. In the studies, it says anywhere from 0 to 13%. I usually quote about a less than 5% chance of lymphedema after sentinel lymph node surgery. But for axillary lymph node dissections, the range is from 70 all the way up to 77% chance of getting this chronic swelling of the arm. And what we now know is that instead of the chance of lymphedema being based on the number of lymph nodes removed, it's actually dependent on which lymph nodes are removed. And so in the axilla, there are both lymph nodes that drain the breast and lymph nodes that drain the arm. And about 15% of these lymph nodes overlap and drain both the breast and the arm. And it's actually transection of the lymphatics that drain the arm that will result in lymphedema. And so now one of the more exciting advancements that we have for a surgical aspect that is offered at Banner MD Anderson is what's called axillary reverse mapping. And so for this, what we do is we can inject a blue dye into the subcutaneous tissue of the arm. And this will identify those lymphatics that drain the arm by staining them blue. And so the lymphatics and the lymph nodes will be blue. And so we still perform the same standard axillary lymph node dissection. If those blue lymph nodes are not in the area that we have to dissect, we leave them alone. But if it is one of the 15% that are in the location that we have to remove because they could be draining the breast, we reconnect that lymphatic, the blue lymphatic, to a nearby vein. And this is thought to decrease the risk of lymphedema. And so studies are showing that lymphedema rates with axillary reverse mapping are much lower. And so it can be performed with a sentinel lymph node biopsy, but typically it's not because our rates of lymphedema are so low. But it decreases the risk with an axillary lymph node dissection down from that 77% to a 24%. And I would actually quote it to be even lower than that with the when an axillary lymph node dissection is done with the axillary reverse mapping. There are ongoing randomized controlled trials that are going right now that will help us more definitively answer this question on how much it does help. And overall with breast cancer, we have great outcomes. And so the 5-year relative survival rates for breast cancer, and this is estimated from the SEER database from 2010 to 2016, for an early stage breast cancer, 99% 5-year survival rate. And then for distant disease, it does go down to about 28%. So overall, all stages combined for breast cancer, our 5-year survival rate is 90%. And again, with the early stage breast cancers that we are more and more often diagnosing cancer in the early stage because of that screening mammogram, a 99% 5-year survival rate, which is really quite wonderful. And with that, I am happy to take any questions.
I'd like to make a comment, if I may.
Yes.
Please, Jim.
I've been very fortunate in that my son has been a radiologist for over 30 years now, and my daughter-in-law, his wife, is an oncology nurse, and she's also a person that they call in to discuss the various problems. But what's really sad to me is the lack of men who take time, spouses, to learn as you are right now with this very excellent presentation, because it's that spouse, that support that's so important. And it's so important for them to understand exactly what you're learning here. So as I say, that's the only thing that really saddens me in a way. Thank you.
Yes, and thank you for being here and for all of your support.
You know, Jim, that's a great point. Maybe we could take this presentation to the men's clubs at the churches and the rec centers just to inform.
Yeah, and I would even add, you know, COVID has really played a role in this too, in terms of spouses not being able to be present during appointments, and because typically spouses can come, and we welcome them to come when they meet with navigators, et cetera, at these appointments. Luckily, we've kind of been able to roll back some of our restrictions in terms of visitor policy, but I think you're absolutely right. And it's one of the indirect manifestations that's not really able to be, you know, counted and reported upon when talking about COVID statistics, but it absolutely plays a big role in patients not being able to have the support system for other healthcare ailments that they're trying to get treatment for during a pandemic. So I think you're absolutely right.
Yeah, thank you. That's a great point. I do have a, oh, excuse me, go ahead.
I have a question. And if you covered it in the first few minutes, I apologize because I was late joining. But my understanding is that there's a percentage of men who get breast cancer. So does all that you both have explained, does that also apply to men in a very similar manner?
Yes, so
Yes.
very similarly, it can. For the surgical options, and Dr. Lawther can speak with imaging.
Yeah, so stage for stage, men do just as well as women, which is great. The exact same, and I do biopsies on men, and we'll do workups for men here as well in the breast center, and we have them sit also in a different area, so they're not, I mean, they're just in their own private waiting room, so they're not, women aren't, who are in their robes, feel comfortable, and as well as the men feel comfortable too. And so, yes, so there are no indications for men to get routine screening, but if they feel a palpable concern, absolutely. It's the same workup and the same process and the same tumor board and the navigators, et cetera. It makes no difference between a man or a woman. More often, men are diagnosed at a later stage, statistically speaking, but stage for stage, they do just as well as women do. Comparatively.
I have a question.
Yeah.
I have a marker in my right breast from that was discovered, a little lump that my doctor wanted to just follow. Mm-hmm. And it was about 5 years ago. So I every year have my mammo done. But you said something about a seed is needed versus a marker. And so, when is that?
Yeah, so that's a good question. They're looking, it's kind of in the research pathways that in terms of, can we find something that you can place at the same time that you don't have to, at the same time of a biopsy, a marker that could also double as a seed, but that's not here yet. That's not anywhere yet. So more often than not, about all the breast biopsies that we do, 70% of the time, those biopsies come back not cancerous. Mm-hmm. So that marker stays in the breast, like you just described. And that marker is made of titanium, and it can stay there forever. Some women have like 10 to 15 markers in their breast bilaterally, different shapes. We kind of laugh or they joke sometimes in that they have a Pandora charm bracelet in their breast because they got a ribbon, they got a curl, they got a dollar, they have all these different shapes. And so that's just titanium, doesn't do anything, no allergic reaction, it doesn't migrate. And these things are teeny, 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 tiny. About 30% of the time, we do a biopsy, it comes back cancerous or precancerous, and it needs to be removed by someone like Dr. Murphy. So at that time, that's when, after your surgery is scheduled, after you've already met with Dr. Murphy, after you've already been presented at tumor board, and we decide we're actually going to do what she was describing as a lumpectomy, removing just part of the rim of abnormal tissue. That's when you would come back the day before or a couple of days before, up to a week before your surgery. And that's when I'd place that seed in the breast. And so then when you go to surgery, the marker, the seed, and the tumor all come out at once.
Okay.
Does that make sense?
Yes, it does. Thank you.
Beverly, I think you had a question, didn't you? Oops, you're on mute. Let's unmute you.
I'll take it off. All right, can you hear me now?
Yes, we can. Thank you, Beverly.
Thank you. What makes the decision as to whether you do radiation or chemotherapy?
Great question. And so they both actually go hand in hand. And so depending on the surgical procedure will be, and the tumor size and the lymph node involvement will be whether or not radiation is recommended. And so you can think of surgery and radiation as going hand in hand and together. Chemotherapy is separate. And so chemotherapy is recommended just based on the size of the tumor and the tumor biology, but it does not matter what you choose to do for a surgical procedure and or radiation on the recommendation for chemotherapy. And so the surgery and radiation are the local treatments of breast cancer. And so they act to prevent this from coming back again in the breast and the axilla. Whereas chemotherapy and those hormonal blocking agents, they treat the rest of the body. They also treat the breast and the axilla, but they also, if any of those cells escape to anywhere else in the body, they clean those up as well.
Thank you.
Of course.
I think Gary had a question, but I'm not seeing that she's still with us. Gary, are you still? Oh, okay. Yes. And then we'll go to Mary after Gary. Gary? Oh, we're going to unmute you, Gary, okay? Oh, nope. Can you unmute?
Yeah.
There we go.
Yesterday.
Whoops.
Can you hear me?
Yes, let's go with Gary first, and then we'll go to Mary.
I have a sort of a peripheral question. As a matter of fact, I was on my way for labs when I found out this was on. I had a lumpectomy almost 11 years ago, and when going for labs now, I did not have the lymphoma. Swelling. What is it? Lymphedema?
Lymphedema, yes.
Yeah, I did not have that problem, very little, when they took out lymph nodes. But now I have a question as to whether I can get labs drawn out of that hand on that side, with putting the tourniquet, on that side. Yeah. I don't want to take a chance of getting the having the swelling problem. And
yes, that is a wonderful question. Yes, wonderful question. And if you ask, actually, depending on which doctor you ask, you probably get a different answer. And so there are no actual studies that have proven that by getting a blood pressure drawn on the same side as a sentinel lymph node biopsy or a blood draw or anything will increase the risk of lymphedema. But we say if you can get it on the other side, get it on the other side, just to decrease the risk as much as possible. But we don't have any studies that say you need to limit that. And now being 11 years out, which congratulations, that's amazing. The risk of it developing now is definitely lower than in those first years after.
And I have to get my draw out on my hand, so it doesn't have to go. The tourniquet doesn't have to go up far on my arm,
Yeah, and so if you would prefer the other side, you could start to do it on the other side if that would be more comfortable for you. It really shouldn't increase that risk.
I'm losing the veins in that other hand. They're getting very
I bet
small.
that other side's getting tired of being poked on like a pincushion.
Okay. Thank you.
Of course.
Thanks, Gary. Now, Mary, did you have a question? We can unmute you and you can ask your question of the doctors.
It's not really a question. Yesterday, I called to have my screening mammogram, annual screening mammogram set up. And in talking to the person that was interviewing me on the phone, I told her that I was going to have my second vaccine on March 1st. And she said that they recommend that women do not have a screening mammogram for 4 to 6 weeks because in some women, the vaccine causes your lymph nodes to swell, and they can't get a perfect picture of whether you have cancer or not. Are you?
That's a really great question. So just yesterday, we had kind of a department meeting, and we're going to be stopping those recommendations. So those were the initial recommendations that had kind of come out, but we don't want to. All we need to do now is we just need to have that history. And so that's what we kind of came up department-wise. We need to have the history. Did you have the mammogram or did you have the vaccine? On which arm, which side, and when? And we get that and have the technologist, because we don't want anybody delaying their vaccine by any means. It's hard enough to get. Absolutely get that first and foremost. We also don't want to delay routine screening mammograms or any sort of screening cancer tests, which have already been delayed enough due to COVID, often than not. So, but that's right. So the lymph nodes can actually be quite become quite large and even angry looking on imaging. But that doesn't really affect the breast tissue so much. And oftentimes, so you may get called back to take a further look at the lymph nodes. But more often than not, if there's nothing suspicious in the breast, then we'll just say, we'll chalk that up and say in our report, like a little line saying that given the patient's history of recent vaccination in the left arm, given that the lymph node that we see that's abnormal is also in the left armpit, these findings are most likely due to recent vaccination. And a paper just came out from the American Journal of Radiology yesterday, which prompted this kind of department meeting and discussion that no longer recommended that we delay that 4 to 6 weeks. I hope that answers. So if you weren't able to get that scheduled, call back today and get that scheduled.
That's what I'm thinking. Thank you very much.
Absolutely.
Well, thank you. I think we're running out of time here. We want to be respectful of everybody's time. As we wrap up, I would like to invite the doctors to share any health tips that you might think would keep us all breast cancer free. I know that's a big, tall order there, but are there any thoughts around any of that that either of you would like to share with our guests today?
I would just say get your annual mammogram. I mean, the screening annual mammogram, it's something that's easy just to kind of put off and I'll do it next week, I'll do it next month. But I mean, it really does make a big difference. Make a morning of it. Go with your neighbor, your friend, your daughter, and get your mammogram every year. Just get it out of the way, do it every year around the same time. And that really makes a huge difference in terms of actual breast cancer survival. That would be my recommendation.
I have the same one. And also as much as you can, live a healthy lifestyle with a balanced diet and get as much as activity as you can.
Yeah, I think that speaks to all of our health needs. So thank you for that. And I think those are things that we can easily do. Well, we certainly appreciate everybody being here today. And I just want to take a moment to remind everybody who's on this call that these amazing services are available to the community because of the community. You know, the philanthropy that has framed these hospitals and these services, which is appealing to these physicians, and they want to work in an environment where there is support for equipment and support for new procedures and protocols is very, very important. So I want to thank everybody on the call for your support in doing that. I do want to ask one favor of everybody on the call. We have some new people on this call today, and I think that you probably saw this promoted maybe on a Facebook page or some other way. We would love to keep you on our list to share other information through additional coffees with Gina. We talk about telemedicine. We talk about the other cancers that we see so much in our lives. We talk about other kinds of healthcare programs. So if you hear from us and we ask you for more contact information, it is simply to just be sure that you're on our list to get these invitations to different kinds of coffees. And so I hope that you'll respond favorably so that we can stay in touch more frequently. I do also want to remind you, and I think we have another slide that talks about this, in support of all of these cancer programs, we are doing our golf event at Top Golf on Saturday, April the 17th. I am not a golfer. My husband's not a golfer, but we went a few years ago and we had a blast. It's just so fun. And of course, Top Golf is being very careful with the physical distancing, but it's still a lot of fun to come together. If you can't attend the event and you want to support it with a gift, we always will accept that as well. So again, we thank you for all that you do. It's been a delight to be together with everyone today. You had such great questions and such great comments. Thank you to both of the physicians. The doctors have presented amazing information. And always, if you're needing to get in touch with one of the doctors at MD Anderson, either at Webb or Boswell, I have their cell phone numbers. So you can give me a call or a text or an email, and they respond very quickly. And that's one of the great connectors that Sun Health has with these physicians at Boswell and Webb. So never be concerned about reaching out to me, to us, and we will see if we can get you on that fast track. Of course, I know that the physicians treat everybody with great care, and we're not talking about preferential treatment, but we do like to help our donors and the family at Sun Health get that kind of connection if at all possible. So with that, again, stay in touch, stay well, stay connected. Thank you for joining us, and you'll be invited to all of our coffees, and any other questions, please email us and let us know suggestions that you have for other topics. And we will see you again soon, and enjoy this beautiful weather. Bye-bye.
Thank you.
Thank you.
Thank you.